a woman a few years ago who lived in a seniors home in Seattle. Her name was Fervid Trimble, and she was she had a daughter-in-law and son in Vancouver. And one morning, she was 87 years old. She woke up. She was feeling a little bit dizzy, and so the next thing you know, she gets called she gets taken to the hospital. And within about a week, Fervid was on about 8 different medications. So she started off with someone who had one medication for her heart, and next thing you know, over the next couple of months, she was put on between 8 and 14 different medications. You might ask yourself, how does this happen? How does this happen that someone who has a slight dizziness gets admitted to a hospital, and then 2 months later they're on a dozen or so medications? There's a certain cascade. I'm talking about specifically with seniors, but you could say the same thing happens to a lot of other people, is that a lot of times when they put you on a new drug, that new drug might help. So it's a drug perhaps to prevent you from getting dizzy. Maybe it's a treatment for your heart, but it causes another problem. Maybe it causes some upset stomach. And so then you'll get a treatment, perhaps another drug, for your upset stomach. That drug itself comes with some side effects as well, and maybe it causes people to have higher blood pressure. And so over the weeks, as they check your blood pressure, you have higher blood pressure than normal, and then you get a drug to lower your blood pressure. And then over perhaps several more weeks, the physician figures out that your blood pressure is actually not dropping, so then they add another one. And they continue to monitor your blood pressure. So of course, you've started off on one drug, you're now on about 4 or 5. Then they add a third drug to to bring down your high blood pressure. But you're 87 years old. What you're not told is that older people naturally have higher blood pressure. Now, and is that a sign of illness? Well, it is in some cases. In some cases, it's a sign just that you've reached a certain age and your body has a higher blood pressure to get blood circulating in your system. You get a third blood pressure pill. Then one morning you wake up and you go to stand up, and the blood pressure is so low in your body that you faint. And you fall and you break a hip. This didn't happen to Fervid, though it got to the point where she was in the hospital for several weeks. When she got discharged, her doctor said that she was anxious and depressed. So added on to the other medications she got was an antidepressant and a drug for anxiety. So now we're up to almost 8 or 10 pills. And in the course of this, those treatments, the anti-anxiety and the antidepressant, really made her quite agitated and quite kind of feeling like her skin was crawling. And she was agitated in the home, and she started to act out a little bit to the people that were caring for her. And the doctor wanted to put her on another drug. And this one was an antipsychotic. Now these drugs, I should tell you, this is probably one of the biggest, I would say probably one of the biggest scandals in sort of pharmaceutical use, is the number of seniors in long-term care facilities that are put on extremely powerful antipsychotic drugs. So these would be drugs like Seroquel or Zyprexa or Risperidol. These are drugs that were designed for people with schizophrenia or bipolar disorder. In Canada, there was, well, in Ontario, there was a study a number of years ago that showed that of all the seniors who are put into long-term care, 25% of them within a year are put on an antipsychotic. Similar data happens in British Columbia. About a third of seniors within a year of being put into long-term care are put on one of these drugs. And I think that, but by the way, the other thing about the antipsychotics is that they have a warning on them. They come with a warning. These drugs should not be used in anyone with dementia, or even close to having dementia. So what you've got is a situation where there's a very powerful drug that should not be used in the elderly or in people with dementia, and is routinely used in people with dementia. And so what are the effects of that? The drugs can cause some fairly severe side effects, including heart disturbances and in some cases deaths. So you might say, well, how could this happen? This person who enters the hospital for dizziness ends up 2 months later on a dozen drugs, including the physician who wanted to prescribe an antipsychotic. Incidentally, this story ends better than that, because Ferber had a daughter-in-law who was a former librarian, and she started doing some research. Every time that her mother-in-law got a new drug, she started to research what were the side effects, what were the potential adverse effects. And she suspected that each time she got a new drug, she got a new set of side effects. And so, this was what she thought was a fairly common pattern. The problem with this is that she was extremely irritated and went to the doctors and said, like, you are drugging my mother silly, or my mother-in-law silly, and can we do something about this? Luckily, her daughter-in-law, Joanna, had a husband who was obviously her mother-in-law's son, who was very much a mediator type, and was able to sort of calm her down and not anger the doctors too much. And I think the key here is that despite how badly you think you're being treated by the medical system, it's probably counterproductive to hit them full bore. It's probably more productive to say, can we relook at things? Can we sort of say, every time Mom gets a new drug, we talk about it. We have a bit of a family discussion and find out what the potential adverse effects are, what the side effects potentially are, and whether, if she starts showing some of these side effects, can we take her off the drug or reduce the dose or try something else? And so really kind of being active and sort of proactive for Joanna's mother-in-law was extremely helpful. It got to the point where they slowly weaned her off of the drugs which were causing side effects. She came back down to 2 or 3 treatments that were effective, fairly safe, probably necessary. And so you ask yourself, how often do people get put in long-term care facilities, get put on these multiple drug regimes just because they happen to be old and have high blood pressure that's associated with, guess what, being older? How often does this happen? Frankly, I think it happens a lot. But at the same time, there is a heightened awareness that the issue of what we call polypharmacy. And this is what I wrote this in this is an article in Reader's Digest that came out last year, it was the year before, March. Too Many Pills, about this story that I'm telling you. And I think there's when stories like this start getting into Reader's Digest, I start thinking, well, maybe the world is improving a little bit. So you might say, what can I do as an individual if I've got perhaps myself or my parent, mother or father, who I think is being asked to swallow too many pills? I mean, there's no easy answer for starters, and it's difficult. And I'm facing the same thing with my own mother, who's actually not that old, but has a doctor that likes to whip out the prescription pad a little too quickly. What kind of strategies do we have to sort of keep this at bay? And I think that most of the time, most of the health issues that we have along the way can be, a lot of times they go away on their own. And you should know that. Like, so if you've got heartburn, or heartburn is a very good example where a lot of older people, a lot of younger people as well, get simple heartburn. This idea that you can challenge your physician, so when it comes to asking questions about the treatments that you're going to get, saying to your doctor, is there any non-drug treatments for this? What happens if I do nothing? Will this go away on its own? And a lot of times, physicians will say, actually, that is something that will go away on its own. I was reading a study this morning that was looking at the rates of antibiotics prescribing. And a lot of people who get bronchitis will rush to their doctor and say, I need an antibiotic. But the interesting thing is that only about 5 to 10% of cases of bronchitis are bacterial in nature, which is to say about 90% of cases of bronchitis don't have anything to do with bacteria, which means if you rush to your doctor for an antibiotic, it's not going to work. It's not going to treat the underlying cause. So, asking your physician, do I actually have something that can be treated with the drug that you're going to prescribe? So asking simple questions of what's the kind of natural course of whatever it is I have, and how helpful would a drug be? Now, I don't want you to walk away with the impression that I think all pharmaceuticals are useless or dangerous or have effects. I think some are very effective and very important. When you talk about people who are insulin dependent, for example, or people who have asthma and need asthma inhalers, people who have migraine headaches or arthritis pain, those treatments that are available, very effective, very important. But that doesn't mean just because something's effective and important that you use it without asking questions to your doctor. What are the things that could go wrong? So you might say, well, where are doctors getting their information about drugs? And this is
Yes.
This is the elephant in the room. And I've written a lot about this and I've studied this. In fact, actually this is this month's edition of Common Ground. I wrote about a concept called academic detailing. Have you guys heard of this before? Well, let me just say that the marketing departments of the pharmaceutical companies depend on hiring salespeople to visit our doctors. That's how they do it. It's done by face-to-face visits, and some doctors, about 2/3 of our doctors, do see the drug reps in the clinics. The drug reps come and they drop off free samples, and the free samples are always the newest, the latest, and often the most expensive treatments out there. And they'll give their sales pitch and be on their way. Sometimes they will buy lunch for the physician and his staff. Sometimes they will ask the doctor if he would like to be part of a study. And as a researcher, I'm all for research. I think we need to know more about lots of things, but the problem is that some of the studies that are supported and promoted by the pharmaceutical companies are nothing more than what we call seeding trials. So a company has a new drug and they want to develop a market for it. But how do you get doctors to use that new drug instead of the other 10 that they've got in the same class? Well, you go to the doctors and say, would you be interested in using this new drug in your inpatients? And we'll pay you $200 for each patient that you enroll in the study. And so the physician, just by giving you a free sample and starting you on a new drug, will get $200 from the drug company. And so, and the physicians may be able to enroll, I don't know, 100 patients. That's a fair bit of cash. Well, what the company is really doing is that they're getting the physician to change his habits, to switch from a drug that he's used or she has used in the past and to use something newer and quite possibly more expensive, and certainly not as proven or as we simply don't know as much about newer drugs as we do older drugs. And so this is a very well-known technique to get people to switch to newer drugs. The pharmaceutical industry spends about $2 billion a year in Canada marketing its drugs to our doctors. And most of that money goes towards these salespeople and the free samples that are dropped off. So Pharmacare, which is the provincial drug plan, has what it's called is a formulary. It's a list of drugs that they will pay for. A lot of times when a new drug comes along, it's not on the list. Why? It might be that it's too expensive. It might be that there are equally effective and safer treatments that are on the list. So to pay for more for an unproven treatment doesn't make sense to them. The messages sent forth by the drug companies are, we're in it to research, the next best cures to save your life, and to some extent they're doing research. But when the research budget is eclipsed by their marketing budget, you might say, well, what business are you really in? Again, the first big drug for osteoporosis was marketed in 1996, a drug called Fosamax. This drug, so it's been on the market now for 15 years. The first trial, the trial that proved its effect, was only 4 years long. There hasn't been a trial more than 5 or 6 years on this particular treatment. People are on this drug for 10 years. So the question is, what happens if you take this drug in the long term? Well, there's a big question mark because nobody knows. But what they're finding is that there are high rates of esophageal problems with your esophagus. There are actually, in some cases, increased risk of bone fractures, which is really very cruel and ironic, because the reason you take a drug for osteoporosis in the first place is to help prevent bone fractures, hip fractures. If you take them in the long term, they're not sure why, but they think the drugs remodel a bone in a way that actually makes them more brittle.
You've written about statins. I wondered if you would comment on them, because they are being pushed a lot by doctors for cholesterol problems.
Yes. The easy answer to that is, if you're a man and you've had a previous heart attack or a heart condition, if you take a cholesterol-lowering drug, and you have high cholesterol, whatever that's defined as, because they keep changing the definition, and you have high cholesterol, you got all those things, you're a male, between, say, 60 and 75 years old. If you take a statin every day for 5 years, it will prevent about 3% of men from having another heart attack. Okay? So, which is to say, men in this high-risk category, 97% of them are not going to have any benefit. That's the most benefit you'll see out of statins. For anyone else, there's either less benefit or no evidence of benefit. And that's certainly true with women, where, you know, these are big trials with thousands of patients. When they take just the women out of the trial, say, let's just look at how these drugs have they actually had those effects in women, and guess what? They find that there are no effects. Even for women who have had heart attacks or previous, there is no benefit to taking cholesterol-lowering drugs. And so no benefit in women, and there is a lot of potential for harm. A friend of mine, and you can Google this, there's a study called Evidence for Caution. It's by a woman named Harriet Rosenberg. That, I think, is the best, one of the best things written about women and cholesterol. And it lays out the lack of evidence of benefit and really the considerable experience of people being harmed by these drugs. By the way, I don't ever get into the definitions of what's high, because they always change. It's whatever they've defined at the moment to be high. In fact, in this book, the first chapter is all about cholesterol. And I can tell you, they've changed the definition of what's considered a high about 3 times in the last decade. And high keeps getting lower. There's also very controversial evidence about whether people getting the flu shot actually are prevented from getting the flu. Because guess what? Most of the time you feel like you've got the flu, you don't have the flu. You've got flu-like illness. But the flu is something really specific. It's a very specific virus. And the flu shot works on that particular virus. When they've done studies, the Canadian studies, looking at people with the flu, they find that only about 10 or 15% of them actually have the flu. In the strict definition of, you know, it's a virus, it's an actual influenza virus. A lot of people have influenza-like illness, and a flu shot's not going to help you.
Have any comments on warfarin?
Yeah, my article last month was on the new drugs that are replacing warfarin.
Yeah.
So warfarin, which also goes by the name of Coumadin, it's a
rat poison.
Yeah, I knew somebody was going to say that. Phil, mischievous. It's rat poison, but it's also you know, widely used drug to prevent clotting, and it's prescribed for people who have atrial fibrillation, which is a heart irregularity. And One of the problems with it is that you require frequent monitoring, or relatively frequent monitoring. So the drug has to, it makes your blood less likely to coagulate, which is to create a clot, and clots are bad, you know, because they can cause heart attacks and strokes. And so this drug is widely used, but because of all the monitoring, the drug companies have said, why can't we try to create something that doesn't require so much monitoring, which means to stop people from having to go get their blood tested and to see whether the drug is working or not. And so they've come up with there are about 3 new anticoagulants that are going to be replacing warfarin. The first one is called dabigatran, or Pradax. And this drug is relatively new. It came to the market in October of 2010. And it already is under a fairly dark cloud.
Very expensive.
It's quite expensive, but it also, when they tried it they studied it in a clinical trial against warfarin. So half the patients got this drug, warfarin, half the patients, and then they followed them for several years. And it reduced the risk of stroke by a small percentage. It was 1 or 2%, but it increased the risk of other kinds of bleeding. Stomach bleeding particularly, and there's some reports of it causing heart attacks. I interviewed a physician, and I talked about this in my Common Ground article last month. I interviewed a physician in Toronto, an emergency room doc, and she said, everyone I know has had a patient who has broken the blood bank. And I said, what do you mean by that? And she said, patients get put on this drug, this is Pradax, the new, and if they have a bleed, they can't stop it. Whereas
I
if you're,
think he said something like that too.
whereas if you're on warfarin and you start to
And
bleed,
there's no
antidote.
That's
With warfarin, they give you vitamin K, it stops.
Yeah.
With this drug, there's nothing to give you, so they keep giving you blood and plasma products and so on.
Yeah, he said if you're in an accident and you start bleeding, that's the end of you.
You know, Pharmacare hasn't yet decided whether it's going to cover this drug or not, and I think that's a signal that they don't want to be spending a ton more money on a drug that's going to replace warfarin, which is cheap like borscht, right? They don't want to spend a ton more money and cause extra bleeds and extra hospitalizations and so on. You know, I might be biased in this area, but I tend to think that if the government's not paying for it, that's a very strong signal to me that it's probably not worth it. I spoke to a doctor, I interviewed him for this book, on the issue of high blood pressure, and he said, you know, 10 years ago, if we had a patient whose blood pressure was 160 over 100, you know, we'd just say, well, it's a little high, but we wouldn't do anything about it. Nowadays, if we have a patient who's 160 over 100, they would consider it malpractice if we don't prescribe an antihypertensive drug for you. So the culture has changed on what's considered to be high. And as you get older, your blood pressure naturally rises. So if you're worried about your blood pressure, you should say to your doctor, what's average for people my age? You know, as one doctor told me once, high blood pressure is better than no blood pressure at all.